In addition to all of that constricting and dilating of the different arterioles and changing of the position of the podocytes on the glomerulus, hormones can also influence the kidney function by changing what is absorbed and secreted. The first hormone I want to talk about is atrial natriuretic peptide. The name for this one comes from the atria of the heart. Natrium is sodium, and uretic means pee, so basically heart sodium pee, and it's released when the atria are stretched. This happens when blood pressure is high. In response to this, what's going to happen is that the kidney is going to decrease sodium reabsorption in the collecting duct. When sodium reabsorption is decreased, this means that there's less of a gradient to pull the water out. Because remember, the thing that's causing water to move is the concentration of solute around that collecting duct. And if there's more solute inside the collecting duct, that water doesn't want to move. What this causes is an increase in both the sodium content of the urine and the volume of the urine. By increasing the volume that's exiting the body, we decrease the blood pressure because now there's less fluid. Similar to if you put air in a balloon and you let some out, the balloon will have less pressure inside of it. The next hormone I'd like to talk about is antidiuretic hormone. Remember that diuretics are things that make you pee. So antidiuretic hormone is going to keep you from urinating, but how does it do that? Well, within the collecting duct, there are channels for water called aquaporins. That allows the water to move from that collecting duct out into the fluid surrounding the collecting duct, so basically into the medulla. In the medulla, there's a salt gradient, and those salts are going to attract the water and get it to move. What antidiuretic hormone does is it puts those aquaporins into that collecting duct, and that makes it so that more water can leave. If more water leaves, this means that there's less water in the urine, so you're peeing less. Conversely, if we block ADH, which is something that's done by caffeine and alcohol, we block the insertion of those aquaporins, and if we do that, now you're peeing more and getting rid of more fluid. So the next hormone I'd like to talk about is aldosterone. And aldosterone is sort of the yin to ADH's yang. What aldosterone does is it increases the absorption of sodium into that area around the medulla. Since water likes to follow sodium, this means that the drive for water to be pulled out of the collecting duct and out of the loop of Henle is actually going to be higher because there's going to be more salt surrounding those areas. And remember, water wants to go where it can dilute that salt. So this is also going to decrease urine volume by increasing the uptake of water. It just does it indirectly by increasing the uptake of salt. Now, these hormones come together in the renin-angiotensin system, which we've kind of mentioned before. Remember that renin is released by the kidneys, and it's released when there is less stretch on those arterioles in the glomerulus, which basically is a signal that blood pressure is low. When this happens, the renin converts something that has been released all the time, which is angiotensinogen, from angiotensinogen to angiotensin 1. This form of angiotensin is still an inactive form. That gets converted to angiotensin 2 through the use of an enzyme that's released by the lung called angiotensin converting enzyme. Once it's converted into angiotensin 2, it results in the release of antidiuretic hormone, which increases water reuptake, and aldosterone, which increases sodium reuptake. This combination makes it for a very strong reuptake of water because not only do we have more aquaporins in that collecting duct, but now we also have more sodium to drive that reabsorption. This is going to increase the blood pressure, which is going to answer the problem that caused those arterioles to not be stretched as far as they should be. Why do we do this? Well, because if you filter too little waste, now you've got more waste in your blood. So it's important to keep the amount of waste filtered by the nephron within homeostatic norms. A common blood pressure medication is an ACE inhibitor. These inhibit that angiotensin converting enzyme. Since they inhibit it, that means that we can't downstream have the release of ADH or aldosterone through this pathway. And by doing that, the person is going to end up urinating more. And by urinating more, we're going to bring that blood pressure down. The thing I want to talk about is not a hormone, but it's a condition that does change your body's ability to produce urine, and that's diabetes. What happens in diabetes is, since you've got excess sugar in your blood because your insulin has not been causing that glucose to get sequestered, this means that when the fluid pushes into your nephron, you're going to have excess glucose within the nephron. Well, what does that do? Remember that it's the solute gradient that pulls the water out. If we have excess glucose in the nephron, now we have excess solute in the nephron, and this decreases the drive on water to leave. As a result, the water stays within that nephron and ends up getting to the bladder. One of the first symptoms most diabetics notice is that they're peeing a lot and they're very thirsty. This is because that excess glucose is dragging the water out of their system. As we go through this nephron, there are going to be transporters that are going to transport things out. These are just channels in the membrane. They may be causing the absorption of salt or other things that, such as water, that we want to reabsorb. Anything that isn't reabsorbed ends up in the urine, and this includes things that there are no transporter for. This is why when someone does drugs, that drugs show up in the urine, because there's no transporter to move the drugs out of that nephron tube. Now, when we look at someone's urine, we can learn a lot about their health. If you were looking at someone's urine and you saw glucose in it, you would assume that they had diabetes. But this is not the only thing that could be there that shouldn't be there. One thing that shouldn't be there on a regular basis is protein. And that's because, remember, when we talk about the glomerulus has those fenestrations surrounding it that keep big things from coming out. In addition, you've got the podocytes, and those are going to make it so that it's even harder for big things to come out of that glomerulus. So something really big, like a protein, has no chance of fitting through this little hole to get into the urine. If we see protein in the urine, that can be a sign that there's been glomerular damage or kidney damage, and that can be dangerous. However, nowadays with so many people in high protein diets, sometimes smaller proteins make it through and they trigger a positive result on a protein in the urine test without being a signal of a pathology. Now, one last thing you might think about that could be in the urine is bacteria or nitrites. And these bacteria are not traveling through the nephron. Instead, what happens is they are getting into the bladder and growing from the bladder. And you might wonder why sometimes people have blood in their urine when they've got a bad urinary tract infection. Well, this is because of the immune response migrating blood cells to that bladder, or migrating white blood cells to that bladder to deal with that infection. Sometimes the urethra gets a little irritated and red blood cells can come in there. So they're not coming through this glomerulus and there's been no glomerular damage. If instead maybe we were to endure a really hard hit on this glomerulus and rip a hole in it, then we might see some blood coming out. So if someone really takes a beating, they might have blood in their urine.